So many of these views that they're going to ask you on the critical care boards are to identify immediate life-threatening conditions. So many of these are going to have hemodynamic failure. Some can be imminently life-threatening. Some will be talking about, using a goal-directed echo to immediately identify certain types of pathology. Once again, ruling out the pericardial tamponade for a classic example. And, when we talk about all patients with shock, I think that you need to use the echo with other pieces of information, with the history and the physical, and have a plan. And that's why we use that goal-directed echo. So what are some of the challenges of using critical care echo, especially when we talk about focusing on the heart, is, when we talk about the cardiac transducer, the probe, it has a very small footprint. And what does it mean is that it has to go between those ribs. The footprint's really small, because what is going to be the enemy of ultrasound? It's going to be bone. So you got to get that probe in between those ribs to get a good view. And that's not the easiest thing to do. It has a small footprint, In the medical ICU, it's really difficult to position patients. One of the best positions to have the patient in is going to be that left lateral decubitus on their side, leading the patient towards you so you can get the heart really close to the, to the probe. But in the medical ICU, what position are they going to be in? Probably supine on their back. And that's probably the only way you're going to get to echo these patients, because they're going to be on a dialysis machine and all the different tubing and cords and the ventilator. So you really can't move the patient as much, So in this supine position, probably the only view you'll get sometimes is going to be that subcostal view. You have to push down subxiphoid to get that view over there. So a key thing I mentioned already is that you want to integrate, You want to integrate the x-rays, the labs, the physical examination, along with the echo to make the best clinical decision of what to do with your patient. So when you're taking a board question, keep it simple, keep it basic. Echocardiography can be very complex. On your boards, they're not going to give you pediatric cases, congenital heart disease, tetralogy, Fallot, transposition of the great arteries. Those aren't the questions they're not going to be asking you. They're not going to ask you very complex valvular diseases. On the critical care board, it's all about goal-directed echo. And, this presentation will really teach you what you need to know to do great on the board exams and to take it to the bedside to help your critically ill patients. So once again, I know we talked about nubdology already, but I'd like to always review some transducer movements that, when you are doing ultrasound and someone says, move the probe, they literally mean take the transducer and shift it to another position on the chest. There's angling the probe to obtain adjacent tomographic planes. You can angle it in a 45 degree, 90 degree, 180 degrees. You could rotate the transducer. And when we rotate, this is done without moving the probe or tilting. And tilting in itself is like rocking along this tomographic plane. So how do we break down goal-directed echocardiography? I put it into three main steps. Number one, as much as possible, try to position the patient. Number two, you got to acquire the images. And there are 5 basic images that we're going to talk about: parasternal long axis, short axis, apical four-chamber, subcostal views, and since you're in the subcostal area already, take a look at the IBC. Step 3 is to interpret the images, integrate the knowledge about the patient, talk about the left ventricle, if you can, the right ventricle, look for pericardial effusions, you can put it together if they have tamponade physiology. So, and look about some basic valvular diseases. So with that being said, let's hit that start button and talk about 2D echo. So what are going to be our basic transducer positions? I put 4 of them down there. Probably the most common one that I use is going to be when we talk about the parasternal. So you always want to think about, number one, the parasternal long axis and short axis views. One that's a little harder to get than you think is the apical four-chamber. We mentioned in the medical ICU, especially during a code, think about using the subcostal. Then the one I don't use as commonly is number 4, the suprasternal notch. And sometimes people do that to look at the aorta. And of course, you want to look at the different imaging planes. So when we do a long axis plane, you can see how it's going to cut the heart in that long axis. A short axis plane is right here. And of course, when we think about a 4-chamber view, whether it's going to be the apical 4-chamber or a subcostal, remember a subcostal is also a 4-chamber view of the heart, get to see all 4 chambers in one shot.